we are about to start the second nursing informatics parallel session. In this session, we will be having three speakers from different disciplines. To start the session, I'd like to invite Ms. Nadika Jayasinghe. She is a graduate from Queensland University with a Bachelor in Nursing, and from Australia, that is. And thereafter, she completed a postgraduate certificate in critical care. And she has approximately 7 years work experience in intensive care nursing in Australia and Dubai. Currently, she is in Sri Lanka, and she is a senior lecturer at the Faculty of Nursing at the International Institute of Health Sciences, that's Sri Lanka. And her current areas of interest include critical care nursing, international public health, and with a special focus on sexual health and vulnerable groups. With her experience in working in the developed world, she's going to talk about using information systems in healthcare settings. Over to you, Nadika.
Hi, everyone. So what I was about to say was actually covered a lot by Dr. Sama and Joanna, but I'm just going to touch on informatics and nursing in Australia. But I wish I had prepared for informatics in Dubai, because despite popular belief, I think that, I think we always think that the West is probably 10 steps ahead of medical and nursing technology. But I actually found that when I worked in Dubai for 2 years, in terms of informatics and technology, Dubai was leading all the other countries. So I know this has probably been said a few times today, but nursing informatics is a specialty that integrates nursing science, computer science, and information science to manage and communicate data, information, knowledge, and wisdom in nursing practice. And nursing informatics supports consumers, patients, nurses, and other providers in their decision-making in all roles and settings. Now, this support is accomplished through the use of information structures, information processes, and information technology. So why is it important? Because we can apply it to our clinical practice and our administration and education and, most of all, research as well. So the sample applications of nursing informatics, we can use it in the clinical area, administration, education, and research. And this incorporates, recording of patient assessment data in electronic health records, recording of workload and interventions as a byproduct of electronic charting. If you look at education, at IIHS, we're doing this already. You've got like blended modes, distance learning, teaching via the internet, recording of workload and interventions as a byproduct of electronic charting. So, these are the areas that the sample, what we could do with nursing informatics. So I'm just going to look at the Australian perspective. So the Australian interpretation of information literacy as defined by the Education and Technology Convergence Report is the ability to use information and information technologies effectively to find, select, and use information to create knowledge and insight. And Theed and O'Brien defined informatics in nursing health as information technology, so computer science, information science, and health sciences that are concerned with patient care, processing data, information and knowledge, and decision-making in the delivery of care. Now, why is it important for nurses? Because in most healthcare settings, nurses do not work alone or in isolation from the rest of the healthcare system. And there are times, though, when nurses do work alone, but we need to remember that the nurses are in continuity of healthcare. So Australian health industry challenges would be decreasing. There's increase in consumer demands, shortage in nursing, and systems change their structures to deliver adequate healthcare. And so how has the Australian government and the public incorporated all of this to improve the delivery of healthcare? So I'm not going to go into this because this is very basic informatics. I'm pretty sure quite familiar with all of this. You have to look at computerized medical care. We've got computerized clinical support systems, which we have in Sri Lanka as well, and in communication technology. We know. And also we've got computerized education for clients. And as Ms. Joanna was saying before, like an hour ago, she was saying how, now it's time to realize that patients are integral and that they're at the center of their own care, and they need to be able to, in healthcare, to be able to provide them with the tools for that. So how do we engage the nursing workforce? We've got 80% of registered nurses, and roughly, approximately about enrolled nurses, we've got about 20%. And the average nurse works 30, and most, so that's 92%, which I would say would be very similar to workforce. The average age of a nurse is 42 years, and you get nurses in cities, regional and rural. And what nurses references and provide nursing content to standardized languages. Like I said before, it enhances the continuity of care. If you think about it, the nurse is the healthcare provider right at the bedside. And so we need to educate our nurses to be able to provide care, improve relationships between providers and recipients of healthcare, and to enable cost savings and productivity goals. So began Nursing Informatics Australia started in 19, training to qualified nurses and health professionals in the use of digital information. So nurses were prime movers in the country of an electronic working environment, governance structure, which I'm going to talk slides, and they need recognition as well. And through that recognition, they can engage further in nursing education in IT through a very systematic and targeted manner. So I'm going to discuss about Health Connect, which it's a change management strategy which was funded through the Commonwealth Government in Australia. And this is the government's support that nurses got in order to, not just nurses, I suppose the healthcare system and the consumer at the end. It's a support that they got to improve informatics, and it was funded by the Commonwealth Government, but it was also with partnership with state and territory governments. It leveraged existing eHealth and infrastructure, and if you think about it, it did some mapping, and it brought together all the, again, eHealth and infrastructure together into one setting. Also, Health Connect allowed information to be readily available and transferred more accurately, quickly between professionals. And this is managed under the National eHealth Governance Arrangements. So with Health Connect, they found that it delivered enhanced clinical communication through standardized clinical messages. It enhanced safety and quality through a shared electronic health record. Also, it integrated models of care through a shared electronic health plan. It made life-saving information available in emergencies. And it enhanced primary care communication networks and allowed consumers to be more able to manage their health care. So the benefits of Health Connect again was that it was an extension of electronic discharge summaries into rural areas. This was the evaluation that they did a few years later to see what they got out of it. And it also developed and increased skills, training and awareness of eHealth amongst not nurses but nurses. And there was a massive, a decrease in the patients and administrative demands required to manage prescriptions for drugs, because all stakeholders had access to Health Connect, and it enhanced quality and safety through e-referral, provided communication. So that's the topic. That was my talk for today. But I also want to just say a few more things. If we aim to, I mean, I think it was all covered before as well, but if we aim to bring these systems, we're doing eHealth Asia and we're doing this conference here, but if we aim to bring these systems from the West into Sri Lanka, we also need to be more mindful of the current challenges we have as nurses here. So we're not just talking about giving them training or providing them with tools to be able to work in the workforce with informatics and e-health, but we're also up against severe cultural, social, professional dementias, and I suppose challenges as well. I know everyone's probably thinking of questions right now, but my question to you is informatics a priority in nursing in Sri Lanka when there are more other areas to, I suppose, cover in terms of nursing, in terms of giving them autonomy and independence? Informatics is our option right now when there are all these other challenges. Thank you.
Thank you very much, Nadika, for that very interesting speak and for the very challenging question that you posed at the end at us, at the Health Information Society of Sri Lanka, probably, and the audience as well. So we'd like to discuss much more about all of that at the end of this session, we will be ending with a panel discussion. So as the next speaker, I would like to introduce to you Ms. Mary Bald. She'll be talking to you about in the digital age. We talked a lot about education in the morning, so I think it's a very suitable topic to bring out at this moment. She's an academic who works with the School of Health Sciences, formerly the School of Nursing and Midwifery, Faculty of Health at the University of Tasmania. She came all the way from there to attend our conference, and we are very grateful to her for that. She has held this position for 10 years and is currently the Bachelor of Health Course Coordinator and Acting Coordinator of Professional Experience Placement. This Bachelor of Nursing Course Coordinator, and she has undertaken unit coordination and lecturing across numerous nursing and health-related subjects. She completed her Master's of Education in 2012 and has a graduate certificate in learning and teaching for health professionals. Her research interests include simulation and technology. And over to you, Mary.
Yes, so thank you for that introduction. And I also do have a Master's in Nursing, so I just thought it would be interesting to let you know that I also worked in ICU for about 20 years, and I've met some of the nursing colleagues here in Sri Lanka in my few days that I was here before the conference, and it seems to be a common theme. And I was also privileged enough to go to one of your local private hospitals, Central, and it was really good to see the facilities that you have there. So I've so far enjoyed my time here, and thank you for having me. I've actually been taking copious notes. I had this presentation organised before I came, but since I've been here, I think there's a lot that I've been thinking about, because I really I feel that I've got a better understanding of the context and situation in Sri Lanka since being here. So I'll probably allude to some new information as I go as well. I'm actually presenting on behalf of Dr. Liz Cummings, Dr. Lisa Dalton and myself, our collaborators with this paper. And it's just invaluable to be able to come to an international conference such as this and share common knowledge and ideas about these topics. And so I'm really interested in question time, and I've been really interested in talking to people throughout the days that we've been here together. A lot of what I'm probably going to say, or some of my slides, are very repetitive, and you've heard similar stories from previous speakers, so I will actually go over those a little bit more quickly. I just think the thing to add here is just a little bit about the origin of the word informatics, and you can see that it comes from the French, meaning computer, German, which is information, so it's a combination of those two. Will contextualise nursing informatics within the healthcare reform landscape in Australia. Currently what's happening in Australia, and hopefully then for those of you that have been to the conference, you can see the differences and similarities between what you're facing here as well. Also, in this talk, I want to try to elaborate why nursing informatic competencies are so important in our context now as well. So, a little bit about Australia. A similar map you saw earlier. The capital is Canberra, which sits just between, which sits in the ACT. We're actually the smallest continent, but we're one of the 6th largest countries in the world, so our land mass is quite large, but our population is only just over 23 million. I come from the very small island down the bottom, Tasmania, and geographically Tasmania is about the same size as Sri Lanka, so you have 23 million people in that little spot, and in that place where I live there are only 500,000 people, and the 22.5 other million are on the mainland. Okay, so just to put it into context a little bit for you. And we are actually divided into 6 states and 2 territories, and this actually becomes significant when we really start thinking about informatics and governance, etc., because what actually happens here, we have a national government and we have policy directives and that nationally, but also each state has its own jurisdiction and its own legislation, particularly around privacy and confidentiality. So we all have different privacy acts, etc. So you can see even with a national rollout of something like an eHealth record, which we have jurisdictions to consider, so lots of communication and thinking around how it's going to work for each state. So it's not as easy as put it up and it all just rolls out, and I think that you're facing that here. I understand with your provinces, etc. This, could pose similar problems in decision making and governance. I've probably spoke a little bit about the population, but I think it's interesting too to think that we have fairly high life expectancies, and I hear here in Sri Lanka your life expectancy is 79, so probably similar. But the interesting thing for us, and I'll talk about this in the next slide, is the distribution of our population. So this little scatter map here can see that most of people live on the coast, in the coastal regions, and predominantly down the east coast of Australia. We also have a pocket of 1 million or so in Perth over in the west, but the big purple bit in the middle with it, not too many dots, is predominantly desert. So we don't have very many people living there. There are Indigenous communities and the like. So we do have people living right in the middle, but so you can see some of the issues that might be posed with getting healthcare and information and systems in a vast land like that. I did a quick check today, and pretty much from the top of the east to Hobart down the bottom, it's about 4,000 kilometres. And if you look from Sydney, the capital, on the east, across to Perth, the capital, on the west, it's about 4,000 kilometres. And from the top down the bottom in the middle, about 3,000. So that's a lot of distance that we're talking about. Okay, so I talked a little bit about the governance structure, and I don't really think there's too much more that I want to add here. But the federal government or the Commonwealth government is responsible for health policy and also for public funding, so funding the public hospitals. And we have a health insurance, like a system set up called Medicare, which covers healthcare, so it is free for all Australians, and we actually contribute to that through our tax system. So we have a Medicare levy, and it depends on how much you earn as to how much you pay, and that's to support the whole population. So we also have private insurance available to us in Australia, and at the moment of people, of hospital beds are in the public, but about 30% are in private, and I understand your ratios are probably even a little bit closer here at the moment, but please correct me if I'm wrong. Just back to the governance structure as well, it's interesting to note that local government and state government get the distribution of funds from the federal government, and they actually then decide how to use it locally, so whether they're going to spend it in their hospitals, in their primary health or whatever. So they actually get the money from the federal, but that they decide how they're going to divvy it up in the main locally as well. And local government, such as is responsible for environmental control and preventative health, such as immunisation. So quite a few different departments involved in the rollout of some of our health. A little bit about health expenditure as well, because I thought it might be nice to just paint the picture. You can see the big blue part of the pie chart is hospitals. So predominantly 40% of our healthcare funds are spent on acute care. And I think this will become relevant in a minute when we talk a little bit about why that perhaps needs to change. And you can see the top chart there is a graph just showing that the health expenditure basically has been increasing over the decades, and this trend won't stop unless we change our healthcare delivery and the models of care and the way that we do things into the future. This slide here is just a little bit about our disease, and you can see here that predominantly cardiovascular disease is the biggest chronic disease or disease processes that we're dealing with, followed by oral health, mental disorders, musculoskeletal, and cancers up there as well in the top few. And I understand that's not dissimilar from what's going on here. And so really what this is telling us is that these most of these are chronic diseases, and so the prevalence of chronic diseases is quite high in Australia, and interestingly most of these are actually preventable diseases. And so this is why I think it's important when we start thinking about informatics and the capacity and uses of informatics into the future, and knowing that it's available for all, and there are lots of apps out there that even individuals can access, that understanding chronic disease, understanding that it's about lifestyle, and understanding the systems that can maybe get right out into the community, etc., will definitely help shape the way of the future. And I think nurses need to be at the forefront of understanding this and being proactive in helping driving what's happening with information, so that right from the patient level through. Okay, I'm just going to catch up with my little notes just to make sure I haven't forgotten to say anything that I really intended to. And I think this slide here is a good one to understand also about the Australian government. Predominantly funds healthcare in Australia. So 46% of health funding comes from the government, the Australian federal government, and state government contributes about 26%. And then the health insurance funds only contribute a very small amount to that. So with increasingly more chronic diseases, etc., and increasing health costs, the government cannot sustain that sort of expense into the future. I talked a little bit about Medicare. I just want to add here a little bit about, we also have a pharmaceutical benefit scheme, which is free medications to patients as well. However, this is highly regulated, so it's not every drug in the world is available to anyone anytime. We have a special scheme and certain drugs get approved by the board and those ones are available, but there will be medications that our patient would have the full cost for. But that's actually determined by that committee. And the private insurance schemes are out there, so we are encouraged to take on private health insurance. So whilst we can get free health care in any of our public hospitals, we can also elect to go to private hospitals if we choose, if we have private insurance. And there was actually an incentive put in a few years back where we got a 30% rebate off it if we joined before the age of 30. And I think it goes up about 2% every year after that. So if you put it off and don't take it, it actually becomes more expensive as you get older. So that was just a little incentive there. And the reason why people would take up private health insurance is because of waiting times in public hospitals and presumably better service. I think I've really talked to this a little bit, so I'll keep moving on from that. I've also talked about the growth in chronic disease, mental health, palliative care admissions. Also, we are starting to see more community-based nursing as well, because there is a recognition now that primary health and preventative care is actually quite important, and it is a focus of the government to spend more money on primary health because they can see that the acute care sustainability is not there. We have a growing an ageing population, so aged care and rural and remote health is also something that we're focusing on. And disability is not on this slide, but disability is a huge area, and we've recently got a new scheme that supports disability. We've gone from being organised in institutions to now individuals a package for their disability, and they choose their providers. So disability care is very consumer driven in Australia at the moment, and it's increasingly going to become more so as that national scheme rolls out. So as a result of increased community care, etc., we have also, the government has put in what they call Medicare locals and local hospital networks. So increasingly now we're moving outside of acute care facilities into communities, and these Medicare locals are made up of teams of professionals, GPs, doctors, nurses, allied health, social workers, etc. So now we have smaller organisations with collaboration from multidisciplinary teams all working together in areas, in regional areas or outside of major hospitals. So again, I'm just trying to paint the picture of the types of spaces that health professionals are working, so you can see the application of how information technology and technology can be supporting what we do. So the use of the electronic record, the medical records, the dissemination of information between all of these places is paramount. And I have just got that final dot there about the personally controlled electronic health record, and that in 2012 it was a national get all Australians to sign up for this, which is, you're looking at a controlled record here in Sri Lanka. Sadly, I have to admit that only in 2015 we have 10% uptake, so only 10% of our 23 million people have actually signed up for this scheme at present. And there are probably many reasons for that, and I think listening today when we start talking about accountability, privacy, confidentiality, those sorts of things, I think we've got a lot of work there to do to convince people and actually to satisfy ourselves as a nation that it is a safe place and that it will be used responsibly by the authorities and in ways that serve us as consumers and not necessarily for government needs. So I think there's a way to go there with that. I'm not going to say much more, except I thought you might be interested to know that people as young as 14 can actually register for a healthcare record. So you can actually, at the age of 14, get your own personally controlled health record, which means you don't need your parents' consent or anybody else to manage those files. So that's just interesting. I think here I saw yesterday it might be 16. Okay, so I'm just going to go on to nursing informatics. So that's a little bit about our context. So with the nursing informatics, you've already heard the definition. It's really science, information, knowledge and management information. And so I'm not really going to say too much more, but it is a combination of those three key things. And I think this slide's the important one. So it's about getting data and information, but what's important is that that data and information creates knowledge, and it's what we do with the knowledge that's important. So the wisdom that we get from this is what is key to us as nurses. So I think, and medical and health professionals in general. So I think we need to be asking ourselves, with all of the systems that we have in place, is like, and think from a nursing perspective in our discipline, what information would really help nurses help their patients? So we are patient advocates at the coalface, and so they're saying, you know, we're there to look after the patients, but sometimes the patients don't necessarily, they trust us to get for them what they need at their time of need, because they don't always know what they, you know, what's important and what's out there. So I think from nurses we can get wisdom from informatics and all of the tools available to us, but ask ourselves what's important, where are we going to spend our time and energy, and at the end of the day, will it benefit our patients? Because that's what we really want. We want those care outputs at the user end. I think just for talking now about training and the competency levels for our graduates, there aren't actually formalised competencies in informatics for nursing, and even though we have had informatics in healthcare in Australia for a good, 3 decades, we are very slow in actually teaching that to our health professionals. So, and having defined competencies about what are the skill sets and the knowledge that you need to work in informatics. And so this is something that we are now just really working towards. And at the University of Tasmania, we are actually about to embark on a new curriculum for our nurses. It's a 3-year degree program. And for the very first time, we are going to embed informatics as a core theme across the whole curriculum. We have other core themes such as clinical reasoning and communication, documentation, those sorts of things, safety. But now we're thinking about informatics in everything we do. And it fits, I think, because when you see how diverse informatics is, all the elements of it, the human, Dr. Tony talked earlier about the human element and the 10 core things that we need as humans to work in that space. Those 10 core things, including leadership, accountability, etc., they can be overlaid across everything that we teach, whether we're teaching wound care, medication management, those sorts of things. Those core human things can be embedded. So we believe that the informatics information is embedded across. I'm not going to really talk about the new technologies because I think the second speaker today, she talked a lot about those, and so we've seen a lot about what they can do, and you've seen some examples from the previous speaker. So the main thing is that we know that they're out there, but we need to be thinking about ensuring that our nurses know that they're out there and knowing how to apply them. And so if we use case studies and things like that in our curriculum, instead of perhaps teaching the old way of this is how you document, these are the legal ramifications for documentation, this is how you would frame it, we might talk about a paper document, but then we might also show in the classroom, or we might get an app and simulate how to do a discharge summary, as opposed to just talking about what a discharge summary is. We will embed as many of the informatic technologies and tools into the curriculum, whether we simulate it or not. That's what we're aiming to do. So I've probably jumped ahead a little bit because I think I might. Will you give me a couple of minute warning? I know that's okay. that in the past we might have traditionally, say for example on wound care, we might have given a lecture on wound care. We then might have done a tutorial, a practical tutorial where they actually practice on task trainers or mannequins how to do the wound care, including your hand washing and your product use, etc., wound assessment, and so on and so forth. And we might have some online materials to support that. So we do a blended learning approach. But what we're saying here with embedding informatics, we might still have the lecture and we still will have ordered learning, but it won't be just wound care. It would be wound care. We might talk about assessment techniques, then we might talk about informatics in so much that we have great databases on best practice in wound care products. So we would bring that website or that resource into that teaching, and so we'd actually be getting students to use that digital innovation and technology, and that's just a brief example. Medication management is another one. There are lots of safety and quality with medication management. There are self-checkout tests and a whole heap of resources. So when we teach medication, we that were working, and every case study would be showing how that would be working and thinking about the aspects of that. And we haven't done it yet. I'll just keep moving. I've got that slide up twice. I'm just going to run it through. I was going to say was that it is important then, getting to the wisdom, is that if we embed it, and it then makes more sense that people can apply it, because just trying to learn it as a discrete thing with how to use information technology, how to look at data, and how to do it in discrete bits doesn't work. We need it all embedded to get that wisdom and use it properly. And this is one of the examples that vital signs, but I've also given some other examples of the types of things there that we might be thinking about using into the future. I've come freely to that, but I hope that that's given you just a little bit of an insight into what we're thinking at the university and how we hope to move forward, and we acknowledge that it is long overdue. Like I said, 30 years of in clinical environments, and yet our students are coming out with very limited knowledge about what's out there and how to embed it in every day. And I think that it is, with the changing technologies so rapidly now, we need to get students to embrace it. And as our first speaker talked about those 10 human things, we need to talk about leadership in this space, and we need nurses to be aware that of how research and teaching and patient care into the future, and that's what we would hope to achieve. Okay, thank you.
Thank you. As I said, you must be having a lot of questions, so we'll have the panel discussion at the end where you can forward your questions to all the three speakers. It is my great pleasure and privilege to introduce the next speaker. Dr. Edusinghe he's a medical administrator with his master's and MD from the Postgraduate Institute of Medicine, University of Colombo, and he's a consultant medical administrator, a hospital designer, and an educator. And he has over 15 years experience in hospital administration, hospital designing and planning, health research, and healthcare education. He's one of the few people in Sri Lanka who is a qualified master trainer from Australia. And he's currently the deputy chairman and the academic director at the International Institute of Health Sciences, Sri Lanka. And also he's a director of the Global Healthcare Private Limited. He's going to talk about the future scope of nursing informatics in Sri Lanka from an administrator's point of view. Over to you, Dr. Kins.
Good morning to all of you all. I have the easiest presentation because as a concluding presenter, you can skip most of your slides. Yeah, being an administrator in the sector, I have seen many installation of many softwares. We call it softwares at those days. Now it has come to a level that we technically call them as informatics. And with that experience as an academic, I thought to give you a small brief on what might come as a challenges for us to face in the future, and what are the strategies that we could move forward to counter those issues. If you look at the healthcare industry, it's very dynamic. We all know that aging population and outside external forces are changing, our healthcare force is changing, technology, etc. Let's look at it, some of the things that how it changes. Last scope, we really look at curing patients, and we are really looking at caring citizens now. We don't call it as patients, we call them as citizens. And focus of it was mainly by the providers, processes, and it was done by a surgeon who did the thyroidectomy in his own way. Now it's not that. Now it's most patient-centric, and it was symptomatic and curative. Now you heard in the morning, it's more preventative and lifetime treatment. And location was the hospital. We invited everyone to come to the hospital. Now hospital has become a big costly giant. It might give you some infections once you come for some other thing. So people love to have their treatment and services provided at the decentralized place or at home or a clinic. And of course the invasive technologies what we have going out of the window, there are less invasive technologies coming in. If you look at the healthcare processes, and it's basically it's moving to a more standardized evidence-based treatment, and more of a disease management, and also the best practices we are moving in. And most of the manual processes are being automated, and that's what we are here for, how we could automate some of the things in nursing care. And then if you look at the information, it was fragmented and it was all over. We had many, we had medical record departments. We had a record department inside the wards those days. Now it's going out of the window. Now it's going to be you can gain information from a click of a button, and it's more consolidated and it's more complete. If you look at the IT, it has changed as well, because these are the variables that come into play as well. It has now it's all integrated. The whole world is a small village. It's all integrated, and data access was difficult, and now it's real time. Data access is there. More systematic management of data, and it's consolidated, and most important is real time data you can access. If you look at information, why we need information in healthcare, just to look at the macroscopic view of this. It's reduced the uncertainty, because hospitals and healthcare provision services has the highest amount of risks. It's if you go inside the hospital and coming out, we have a major risk than going to moon and coming back, because so many variables can happen inside that particular hospital stay. So why we need information to reduce uncertainty to the healthcare, of course the healthcare risks. Of course this will definitely lead to the safety and of course the good patient outcomes. And with information, if you have proper information, you can reduce the repetition, and that will fast track the decision making. and of course the system will become more efficient. And then you need information for day to day, because things are changing, because today's knowledge, tomorrow's history. So therefore you need you will need continuous input of information to upgrade your knowledge. And this will of course reduce the at the end wave of the conflicts within the hospital context. And of course, at the end of the day, more important thing as a system is that it improves the patient care quality and the cost. Of course, healthcare is being extremely expensive service element component where the government or the private sector has to absorb. So very important to reduce the cost as, of course, whilst looking at the quality. If you look at the categories of information system, broadly we have MIS, TPS, DSS, and EMS. If you look at the TPS, transaction processing systems, are at the process level. Systems are at the process level. If you looking at nursing informatics, we are looking at TPS and DSS. Of course, it's highly technical, but just wanted to put these things across to you. If you look at the health information, public health information systems, and we have hospital-specific information systems, and then of course as a component of HIS you have the nursing informatics systems. Why manage health information? Because each patient encounter we produce information. That encounter, each encounter we have to make decisions, right? With each decisions you require a specific output as well as the outcome. If you reduce repetition, of course, it will increase productivity and the quality, of course. Then let's look at the history of nursing informatics. I found it in the web. It actually started with none other than Florence Nightingale. She came out with a pie chart describing the infection rates versus the clean environment. So she's the one who actually started information. As it's not as she's the mother of nursing. In 1950, Walter Reed Army started Harriet Worley. She started working with IBM to introduce some computers in healthcare. In 1950, Rita introduced the first paperless physician order entry. 70s, University of Michigan came out with the nursing diagnosis. We all know the nurses. It's called Nanda method. Then 1973 moved into more diagnostics in nursing care. 80s, personal computers came up, and then the nursing informatics slowly expanded. And in 1988, University of Maryland introduced the first graduate nursing program in nursing informatics. 89, again it moved on to more expansion in the sector. 1990, internet and the web-based application came into action. 1995, nursing informatics was established as an area of specialty to practice, and of course 2004, President George Bush of USA looked at nationwide electronic medical records. So from there onwards, it has become it's on a very fast track, and it has evolved into a very high-end component of day-to-day practice. At a hospital, what we do is, of course, the quality and cost effectiveness is the important objectives of giving care. And what we do in the hospital, we do loads of interventions. And of course, interventions, we can't do interventions without assessment. You have to assess the patient and do your activities. So for assessment, you need information. So, and then once you do the activities, you produce information. So, I mean, hospitals are one of the institutions that creates loads of information. So it's empirical that we look into this and manage information properly. And if you look at there's subjective information, there's objective information we produce, there are operational information that we produce, and social information that come into action, because it's health is a part of integrated system of society as well, and medical community, and there are assessment reports, planning reports, diagnostic action, therapeutic action, care action by the nurses. All these will get together and produce enormous amount of information inside the hospital. These are some of the areas, I'm not going to go into details, where nurses will get involved day-to-day processes, healthcare monitoring, clinical decision making, the tasks that they have to conduct, and scheduling processes, work listing, and form generators for individual activities, and workflow monitoring processes. All these will create information, and as well as we have to manage those information. If you look at a country like Sri Lanka, and we have the free health in the public sector, and public sector has been managing, now currently we manage 50 million OPD patients a year, and 5 million inward patients per year of a 21 million population country. It's a huge amount of load that comes into the system, but still we manage it manually. So therefore manual systems are running, and it's time that we look into automating certain processes. Role of nursing and nursing informatics. If you look at role of nursing, nurse would be the front end of care, and out of all the health professionals involved, nurse will be right beside the patient 24/7. So she or he is the one who will produce more information than any other healthcare professionals. So they'll have to plan care, they have to monitor, and then of course evaluate the patient care outcomes and outputs. It's done at the nurses level. So when you look at putting up a healthcare information system, it's mandatory that you look at the nursing care processes, because nurse is the one who would ultimately at the grassroots level of care. So nursing informatics, of course, obviously a choice that you would really look at before you come into invest in healthcare information systems. Of course, this was mentioned before, that is a specialty that integrates in 3 main disciplines. And it covers the clinical practice, administration, education, and research. What are their roles as a nursing informaticists? What they do is they would standardize the documentation of the of hospitals that are used, and of course they manage information. They look at the processes, and they would look at the bottlenecks of the process or the red tapes. Then they would advise on the process re-engineering, automation of certain areas of clinical in all clinical departments. And of course they would look at this information will be used for evidence-based practice and research, and of course that will definitely go towards the patient-centric care. And it, of course, once you have information coming into you, you can be the change agent in your institution. So of course they would really look at not only clinical data, they would have to look at financial data as well. I mean, as healthcare professionals, we are a bit shy away from the finances, but you will have to face it, because everything is a cost. So we have to get into financials. We could really choose what's the best cost-effective way of treating a patient. Of course, parallelly, they would look at facilitating the resource access and utilization, our equipment, our staff. All that is important. And also, from the patient point of view, they will enhance the continuity of care. Handing over, taking over, all these are manually done. Of course, this could be automated up to some extent. Then, of course, it improves the relationship between the staff and patients, because there's a continuity of communication between the staff and, of course, the patient. And, of course, as I mentioned before, it will improve the quality and cost saving. And most importantly, healthcare is delivered by a team of professionals. Unfortunately, these professionals are trained in different disciplines. Doctors are trained in medical schools, nurses are trained in nursing schools or universities, paramedics are somewhere else, and the administrators are trained in somewhere else. We bring our own values, we bring our own disciplines from our schools to our profession, but at the end of the day, you treat the same patient. So how will you make interdisciplinary collaboration and teamwork? This is nursing informatics would definitely support you in doing this. So what are the challenges in nursing informatics today in this part of the world? It's a we know that it's a well-developed field in the Western world. It already play a major role. We heard all the speakers talking about this some time ago, and it has given definitely a good desirable outcomes. But in developing countries, as Nadika posed the question, that is that the thing that we have to really focus on? Is it a priority of developing world? Are there any other things nurses could do than focusing on nursing informatics? Of course, that will be answered during the discussion in a while. And those are the challenges, those are the arguments that we will have in days to come. One of the issues that we have seen in lack of training. If you look at being a medical administrator, project manager in many hospital projects, I've seen the hospital funders or the owners would love to put into this fancy HIS system into the system. I've hardly seen in Sri Lanka even 20% of those are used, especially at the grassroots level. At the nurses level, of course, that I have seen. So simply because it's lack of training and focus, and also the clinical environment should give the priority for this sort of automation that is not available in this part of the world. And skills and knowledge, I spoke to you, and of course the IT literacy in nurses. That is also one of the key challenges that we have to really look into. Of course, giving more IT-oriented modules into their curriculum is mandatory at this context. So what are we really have to look into organizing a proper strategy in moving forward. Simply, you heard yesterday at the inauguration, the Director General of Health Services, Dr. Palita Mahipala, he had loads of objectives in his mind, and he has a vision to make more e-health into the system. So therefore, our nurses will have to be equipped. That is the largest force in Sri Lanka as well. We have 30,000 nurses in the public sector. So they will have to really geared to do this. So strategy, few things that from the point of view of the administrator, understanding the key nursing care process is very important. That's where all the data, all the informations are produced. Aligning with these processes, you could really look at organizing the hospital patient care systems. From that also, you can prioritize key result areas. Key result areas are the ones in a process which gives the highest amount of risk and highest amount of change. For example, registration of a patient, though it's at an administrative level, that could change the patient outcome at the end. If you take the Siripalas, two Siripalas coming into the same ward with A Siripala and G Siripala, one has a hernia, other one would have appendicectomy to be done, appendicitis. So they could change, because at the registration point of view, if you make a change, if you mix the two, then outcome will change. So therefore, it's very important to identify administrative as well as clinical key result areas, and then measure and validate the areas that you spend more time wasters, and of course the quality wasters, because sometimes you don't get you have long waiting time. There's a stagnation in that process, as well as when you look at the outcome, those are not coming up in certain areas. So you identify those areas from the clinical point of view. then then organize a new system properly, a good process to eliminate those bottlenecks and red tapes. Then, of course, you can automate the repetitive and clerical work done by the nurses. If you look at the public sector, even in the private sector, I think 30 to 40% of their time are spent on basic clerical work. And there are loads of accountability issues that we have in the government sector as well as the private sector. They are accountable for a certain amount of drugs. So I've seen, if you go to a ward, you would see they're counting drugs, whilst their clinical nursing care is more important than counting drugs, tablets, and entering them in books and books and books. So those things could be automated as the time goes on. Of course, once you reduce the repetition, you give them more time, you reduce the burnout of nurses. Now, currently they do to average at least 2 shifts is not a new thing, because sometimes they do 3 shifts and extreme 72 hours in a place and standing, and it's not easy. So these are the things that to improve the quality of life of nurses, definitely nursing informatics and the process changes would attribute to that as well. And most importantly, you should give the leadership to the nursing care processes. Typically, these softwares, information systems are brought over by the administrators or the clinicians. They bulldoze the whole system with their system, and they just implant it, and they call it computerization of the system, which that's the word that most of the administrators would use. And they forego the value add by the nursing staff. So therefore, very important to give the leadership to the nursing staff and the nursing care process in the implementation of these new softwares. So those are the things that I have to, the few things that with my experience and the knowledge that I gathered over the years to put forward to you. We'll take up the questions in a while. So let me take this opportunity to thank Healthcare Information Systems, Society of Sri Lanka for inviting us to giving this opportunity to come and participate in this particular forum, and of course Professor Vajit Dithanayake, the chairman, and of course Dr. Nishan Silva, the organizer of this particular forum. Thank you very much. It's nice to share our views, of course, gathering the international knowledge. We thank all the international participants and as well as the local presenters. Thank you.
Thank you very much, Dr. Ketsire, for that informative speak. And ladies and gentlemen, now it's time to have a panel discussion. We like to invite the 3 speakers up to the podium. We'll put up some chairs to line up with the cameras, because this is being webcasted. And also I would like to invite on a couple of other others from the from International Institute of Health Sciences, the organizers of this session. Ms. Dilum Valivita, a registered nurse who practiced for long years in the United Kingdom. She's a graduate from there as well, and who has a lot of experience working with the information systems of the NHS. And also Mr. Tarindu Dushyanta, a graduate nurse, and probably the only nurse in Sri Lanka who's involved in learner management systems and virtual learning environments probably for the last 4 years, as I understand. So we'd like to have a panel discussion involving these panelists, plus many other key people in the audience as well.
Well, it's time to take some questions from the audience.
There's some questions come from the audience, like to ask a couple of things. We heard a lot from the speakers, but let's hear a little bit from the others as well. Ms. Delum, like with your experience in the United Kingdom and with your involvement in with the local nurses, like back here in Sri Lanka again, how can a nurse who's trained in a traditional environment be transformed all of a sudden into an electronic environment? If you take one of our nurses and go and put her to work in the United Kingdom, what would it be like?
Good question, Dr. Ishan. Thank you for giving me this opportunity. If I recall my memory with nursing in UK, so what we do in UK is like basically in nursing informatics is part of the nursing curriculum, and we train them from the day one in the university. So it won't take that much of time them to get used to the system when they really start practicing. I think that's make a huge difference. That's something you have to think about in adding into the nursing curriculum here. And also I can remember now, like those days we used to take the drug trolley to patient. Instead of that, now they're taking cows. Cow mean computer on wheels, or the iPad. That's how the system is there now. And also, like almost major hospitals, they have gone paperless. Everything from the care plan, nursing assessment, ordering, medications, everything we are using the informatics there. And if anyone, or we are thinking to move into that stage, so we have to start from the curriculum level here. Train them from the day one. Because Ms. Nadika have mentioned a question which is really good. Actually, I felt, but no harm. We have certain priorities in Sri Lanka. There are so many things need to overcome before we come into the informatics. But it should be no harm done if you learn and if you can put your hands onto the informatics and learn it and move forward. Otherwise, we will not be able to fill or match the gap where the UK and Australia is now currently. I believe you also agree with that, right?
Yes, sorry. I just wanted to add to that because I did forget to mention it with one of my slides and around curriculum. One of the drivers for UTAS to embed informatics across our new curriculum is that we're very aware that the Australian Nursing Council that governs our practice is releasing some new standards in 2016, and as part of those new competency standards for nurses in Australia, informatics is definitely going to be written into those for the first time. So we believe that we'll be one of the first universities in the country that actually will comply with the informatics requirements of the new standards of nursing.
Let me add certain points to that comment. Looking at how to train the existing nurses on informatics, and of course we have some academics here. They would look at how to add that into curriculum. It's not there at the moment. So those are some of the areas that they are looking at. Of course, CPD, the Continual Professional Development Programs, is mandatory that you look at nursing informatics as a program.
We can have some comments from them as well. We would kindly like you to introduce yourself and add some comments.
I'm Dr. Sudhakar Surya, Present Coordinator at the University of Sri Jadhanapura BSc Nursing Program. I have several questions I noted down while you are doing the presentation. First thing is, I'm not clear, this is a new area for us in our program. There is no such a module or curriculum content for nursing informatics, but we give IT education during the degree program that means they know how to do the thing. The student also use this smartphones and all the computer presentation or other assignment they do in using the computers. What is the difference and also the medical informatics? The same thing you.
Shall I? Yeah, health informatics is a large umbrella where within that you have public health systems and hospital health systems. And within the hospital health systems, you have the nursing informatics coming within that. Some would go into public as well. But originally, the total process would start from the nursing arena. They are the ones who do the nursing care process. So this is supplemented by the medical consultants support as well as medical officer support. So it's a grassroots level care plans as well as the total assessing, the nursing care process that was aligned with the nursing informatics. But it has gone to many other areas as well. It's gone beyond with the technology. They have gone into different levels of provision of care at lowest cost with the highest quality. Did I answer your question?
And a comment from the delegates from Nursing Council as well.
Thank you very much for giving this opportunity. I think this workshop is very valuable for us. I think as nurses, we should apply this knowledge in nursing informatics into our nursing practices. Nowadays, we help to do curriculum revisions. Therefore, we can add this subject, I think, into the nursing curriculums, and it will help to introduce this subject to the nurses.
Thank you very much for your comment. And since there's a lot of talk about education, Mr. Tantu, would you like to comment on, with your experience with the diploma and graduate level nurses who are engaged in learning through the distant learning modes, the online distant learning modes, the learner management systems and the VLEs, how receptive are they? Like, are they okay with it or are they comfortable with it?
Thank you, Dr. Nishan. I think I see a clear gap between what has been delivered through curriculums for students and application of those skills and knowledge in terms of IT, information technology, where there is a clear gap. Because most of the time what we see is nurses who mostly even in any other health fields where they do have IT literacy. If like honestly speaking, if you ask how many of you have Facebook accounts, like most of them do have Facebook accounts. But the problem is how capable of them using their IT literacy for new applications and innovation or for any other purposes. I see a clear difference. I mean, like a gap between what they have been doing and what they're supposed to carry out. Where from my point of view, I like even when it comes to healthcare systems or nursing informatics or HIS, hospital information systems, I see some hospitals, we do have currently hospital information systems, but I have the doubt how much do they utilize these facilities. Because we look at most of the private sector hospitals and all, like they do have hospital information systems, but the thing is, like, I don't see people using it much. So my opinion is, I see two problems with regards to this. The first thing is problems with so it's not that implementing the hospital information system and then trying to train people on that particular application or information system, but that has to be integrated to curriculums. And that again, not only for nurses, but for any other healthcare professional, because like though we call it nursing informatics, and but if, as Dr. Kitsiri mentioned, that is a huge or vast area, that hospital information systems, where other healthcare professionals and nurses are put together and interact together through information systems to make client care delivery effective. So where I see that the nurses and other healthcare professionals has to be trained on IT, basic IT literacy, as well as usage of these applications in healthcare arena to make it effective. The second problem that I see is, well, again, as Nadika questioned during the last slide, that is that the priority? I guess like that is one of our priorities, because we see plenty of medical negligence which has been like, you know, which occurs again and again, and certain things are very simple things which can be avoided or prevented very easily. So I think, like, for an example, if you look at a medical prescription, if you do that through a system, let's say you mark client is allergic to paracetamol, and then like a doctor or nurse prescribe the medication, if a pop-up comes saying it's allergic, so how convenient that will be. So that is where I think, like, you know, that is the real beauty of health systems. So, well, as Nadika mentioned, the problem is not the priority, I guess, like how we are going to put it into practice. Because what I see, we do have hospital information system, nursing information systems, but then again, we have the system, we maintain it. Apart from that, we do have the manual things as well. We keep, like, you know, all the other records. Why this duplication? So then the nurses or any other health worker would look at it as a burden. Why do we repeat? I mean, that is one point that you, like, I think as people from healthcare background, as well as informatics, so we should be looking to.
Thank you very much, Tandu. And there's a question from, I'd like to introduce the one who's going to ask the question, the vibrant General Secretary of the Health Informatics Society of Sri Lanka, Dr. Chaminda.
Thank you very much, Nishan. My question is also quite connected with the earlier question, like whether this health informatics, medical informatics, nursing informatics, then how many informatics will there be? Shouldn't it be so produces a device, they don't send a manual with them, because it should be intuitive. You should be able to, if you have a general IT background, you should be able to use it without formal training. I think when we have informatics, we should have all the people as stakeholders and deliver larger the hospital information system, rather than you know, compartmentalizing this informatics, and people, you know, ultimately might fight over what's my part of this, and like, so we have to promote from the inception that these are multidisciplinary things, that everybody who is a stakeholder should get together and work together to improve the health ultimately, because nothing is about e-health or, you know, informatics. We are looking after the health of the citizens. That's what I have to say.
Thank you very much for that interesting and a challenging comment as well. Would the panelists would like to add something to that, or anyone? Or like to any of the comments that's been going on?
this is for the nurses who are currently practicing. I would like to say in UK also we really find very difficult to implement at the first time, because who are existing nurses, we have to send them for a special training, and it costs quite a lot of time. But believe me or not, it will take it will save a lot of your time, and which we can use it for the patient care and your critical thinking, clinical decision making, rather than writing documents here and there. So I really believe if you can really getting into it, your time will be more saved. And especially nurses are quite famous to say we don't have time to do this and that. So then you will realize you will have a little bit of me time for everybody. Thank you.
Thank you. I might just add to the question, and also what you were talking about nurses not having the skills, the IT skills that they need. It's actually true in Australia. There are assumptions that the nurses are proficient, particularly the younger generation, and perhaps they are with some aspects of it, but not all. And so we can't assume that they have the basic skills that they need to work in that environment. Back to the question, at the back of the room, I agree about that it should be for all. The informatics and the technology that we use should be generic, and so that everybody working within the healthcare sector, whether it's in Sri Lanka or Australia, should have the basic skills to use the apps or the programs that are there. Linking that back to training, I suppose the challenge then for training organisations or curriculum providers is that what is a generic enough space to start that IT training, so that we can then apply it to most of the technologies and apps that we're using. And then that begs the question to the people that are planning, and we've heard a lot in the last few days about the strategy, the framework, the architecture. So it's not just about how we teach people to use it, but what we need to be doing is putting the architecture around the design that gives a generic platform that's easy to teach across disciplines.
Any more questions or comments from the audience?
This is more of an observation rather than a question. Coming from a background where the nursing practice, the medical professional practice, is governed through some very strong compliance infrastructures, clinical governance focus. So then translating education into actual practice becomes that much more structured and probably achievable. I'm just thinking in terms of Sri Lanka. It looks nice to have the nurses educated offline with courses and so on. At the end of the day, at the bedside, it needs to translate into a behavioral change and a practice, and it should be consistent and reliable. How do we do that? So I think the commitment must come not just from the nursing, but from the whole medical fraternity within the hospital, which governs it, monitors it. People respect things which are measured and monitored. So I think that's the transformation that Sri Lanka needs to do in parallel with the educational growth. So that's just my comment. And that's the challenge, getting everybody conformed.
Thank you very much. I think Professor Tony Sama's first things in the list of 10 was leadership. So maybe Dr. Kitsiri would like to add something to that comment on how to go ahead with this.
This is aligned, not really aligned with the informatics, but it's a general comment where, of course, we are replacing the caring hands with some devices. It was mentioned in many few presentations. Where would the caring hands would go? Not only nurses, but the medical fraternity as well. Day in, day out, we see the patient loads are immense, and specializations are growing. So instead of a general physician, you have a specialist in certain area, endocrinology or cardiac. So they would see only a specific patient. So their times are limited time. So that's where the nurse would have to absorb of that the deficiency in care. In terms of the ethics and regulatory norms, they are there. They have not been changed for centuries. It has not been changed. But implementation of those will take loads of time, because as administrators, they are bounded by, especially the medical administrators, they have so many limitations in terms of at least controlling or coordinating among these high-end professional bodies. That's a challenge, day-to-day challenge. But I think the nurses will have a role to play in this arena to fill that gap in.
I think though the discussion is very fruitful and interesting, we have run out of time. We are already 5 minutes late, 6 minutes late. There will be a lot of other activities happening in the main hall. So I would like to conclude this session. I'd like to thank all the presenters and the panelists, and of course the audience, for their attentiveness and for the questions that they forwarded. Thank you very much.
Thank you, Dr. Nishan. And I would like to invite Dr. Nishan again to award the certificates to our distinguished speakers. And at the same time, I would like to invite all three speakers to come to the front. Ms. Nadika Jayasinghe. Ms. Mari Bibol. And finally, Dr. Kitsuri Edrisinghe. Thank you, Dr. Nishan. Now it's the time to launch the e-medical center system and then the plenary on the IT governance of health domain, which would be held in the main hall. So, ladies and gentlemen, let's move to the main hall to proceed. Thank you.